So it's my pleasure this morning to introduce Dr. Teresa Zwolan, who's Cochlear America's Director of Audiology Access and Standards of Care. Dr. Zwolan was a professor at the University of Michigan, and she's a professor emerita now in the Department of Otolaryngology, Head and Neck Surgery. And I believe you were the director of the Cochlear Implant Program for many years.
That's right.
And she's a past member of the board of directors of the ACIA, and she has involvement in a number of other organizations as well.
Okay, well, first of all, thank you so much for inviting me to join you today, and thank you to Dr. Ellsberman. I had the pleasure of working and collaborating with her at the University of Michigan. So I love to talk about cochlear implants and especially about access to cochlear implants. I'm going to take us back just a little bit. All right, so we know cochlear implants have come a long way, and when they were first introduced, patients needed to be bilaterally profoundly deaf and to demonstrate no benefit from amplification. I remember turning away patients who scored 4% on a sentence test, and we had to turn them away for a cochlear implant. I love showing this slide of Richard Dahl up there on the top. And then I have a patient when I retired sent me this picture of she and I from the 1980s. That's her on the left. That's me on the right. I don't know if that ages me or shows historically how cool it was to be on the ground floor when these devices started. But if we think about how far implants have come, candidacy looks so different. Technology looks so different. And outcomes have really exceeded early expectations. If you asked me in the 1980s how good the outcomes would be, I really never imagined that they would be so good, especially for young children. So we know that they work. There's recent studies that indicate patients are experiencing great improvements in both word and sentence recognition scores. So if we look at CNC words. So this is a recent study with the CI 532 led by Craig Buckman, where CNC words went from preoperatively 15% all the way to postoperatively 46-point improvement to an average of 61%. If we look at AZ Bio sentences in noise, we have a pre-op score of about 15%, and in noise, we're going up to 43%. So I like to show this study because it had a large N of close to 100 patients, and these were a variety of adults. And we know that they work in older adults too. If we look at this study that was used to help Medicare expand their indications, we had patients who were all over the age of 65 years, and the data was so strong. If we look at their best aided scores preoperatively or their implant ear alone, we're seeing such nice improvements, very similar to what we saw with that adult trial on both sentences and words. These sentence scores are a little bit higher because they were in quiet, which is what Medicare wanted us to do, but those CNC monosyllabic word scores are actually 1 point better than they were in the 532 trial. So there's great news, right? We know that these things work and we know we're getting excellent outcomes. The bad news is only about 1 in 20 adults who could benefit from a cochlear implant receive one. And when one considers expanded indications, it might be even lower than that. So what's happening is our outcomes keep improving. We're expanding indications. But as we expand indications, that means more people are eligible for them, but we're not tapping into them. And so it seems as though fewer and fewer people are being served by this technology. Fortunately, it's slightly better for children. In the United States, about 50% of children who could benefit from a cochlear implant actually receive one. But for children, this technology is even more important. And why aren't more children receiving cochlear implants? And a lot of people hypothesize as to why that is. We feel that sometimes clinicians wait for children to perform poorly with hearing aids before considering referral to cochlear implants. So rather than looking at an audiogram that's severe to profound and saying they meet indications, they want to put them in a trial with hearing aids and wait for them to fail before they can improve. And sometimes that means it's too late for them to reach their optimal performance. Indications remain strict, especially for children. The indications are stricter than they are for adults, and that often prevents referral and implantation because clinicians continue to think you have to have absolutely no hearing in order to receive a cochlear implant. Indications really focus on audiologic measures because I think early on that's really all we had for children. But they fail to consider other factors that we've learned really contribute, such as speech and language development, academic performance, all those things that clinics are now looking at when determining if someone is a candidate for a cochlear implant. And parents remain concerned about surgery despite excellent safety records. I could understand that early on because it was such an unknown, but we've been doing these for years and we've been demonstrating that they're safe and effective, yet parents still come into our clinics expressing concern about having their child undergo surgery. Some additional contributors or possible contributors to low implant use is primary care doctors, audiologists, hearing aid providers, and really the general population are not familiar with cochlear implant candidacy or when they should refer someone for an evaluation. I do believe that we have very poor communication between cochlear implant clinics and hearing aid dispensers and diagnostic audiologists. We're very siloed into our areas of practice, and we don't have much overlap. And I think sometimes the hearing aid audiologists feel like those referrals just go one way, and they're going to the implant clinic and they send a patient there, and sometimes they never find out what happened to that patient, but we'll talk about that a little bit later. And importantly, there are very strict, outdated FDA indications. The indications we have for adults with traditional implants have been in place for more than 20 years. And what has happened is a lot of clinics are sort of taking criteria into their own hands. Many of them are requesting off-label approval from insurances. They're going outside of those FDA indications, and oftentimes insurer indications differ from those of the FDA. So that adds to confusion for clinicians, for patients, for payers, for everyone in terms of really who's a candidate for a cochlear implant. So for example, if we look at these FDA approved indications, we've got our traditional patients who need to have a bilateral moderate to profound sensorineural hearing loss, and that aided sentence recognition score less than or equal to 60%. We know that Medicare now has expanded to be the same as that, so they're similar to the FDA indications with that sentence recognition score. Children need to have a bilateral severe to profound hearing loss. So again, they're stricter, and their word recognition needs to be less than or equal to 30%. That means these children are missing 70%, and somehow that seems to be okay, that they could miss 60% and still not qualify for a cochlear implant. We did a little bit better once electroacoustic devices were introduced. We were able to expand it out, and that's the audiogram on the bottom right-hand side, where adults with normal low frequency hearing and severe to profound mid to high frequencies could qualify for a cochlear implant. And when we did that, so traditionally, at least in the 80s, we really only implanted people that had corner audiograms, and they were audiograms that only had hearing in the bottom left-hand corner. And now, if we look at the audiogram on the right, that entire audiogram, except for the top right, is sort of game for cochlear implants. We could shade in that bottom left corner, and that audiogram means that someone with an audiogram that falls anywhere there outside that upper right-hand side could be considered a candidate for a cochlear implant. So no wonder our referral sources are confused, because you can't really just look at an audiogram and identify that someone's a clear-cut candidate for a cochlear implant. What has helped is that we've had recent approvals from the FDA, and a lot of those approvals have been based on real-world data. So they didn't have to conduct expensive clinical trials. They looked at real-world data to approve single-sided deafness for both children and adults, asymmetric hearing loss for children and adults, and then also reduction of the age of implant to 9 months of age. So here we do have an audiogram that you can easily identify as single-sided deafness. So we have approval for SSD, but if we look at those criteria, they have to have a severe to profound sensorineural hearing loss in one ear, normal hearing in the other, but they have to have limited benefit from an appropriately fit unilateral hearing device defined as a CNC word score less than 5% in the ear to be implanted. And as an audiologist, when we test patients like this, we put a really powerful hearing aid on that left ear. And what's going to happen is it's going to be picked up by that right ear, and probably the crossover we're going to get is going to put that CNC score above 5%. So even though we've expanded, we still have very limited indications that are oftentimes keeping some of our patients away from receiving a cochlear implant. But one of the good things about single-sided deafness and asymmetric hearing loss is that we're finally focusing on the ear to be treated rather than basing all of our decisions on how well a patient hears when using both ears. So that dilemma regarding best aided condition, which has never really been clearly defined for us as clinicians, but we're starting to see that some people are taking control of that. And I'll go into that in a little bit as well. Additional impacts on access to cochlear implants are the insurer requirements. Not all states have Medicaid coverage for adults. Medicare does, and they've recently expanded, which is great. Private insurers really vary greatly in their willingness or their ability to approve payment outside their published indications. So you might have a private insurer that says, sure, I'll consider, send me a letter. And other ones say, I won't look at a letter, you just have to follow our indications, and you can't even ask. So it's very hard to know based on a patient's insurer if they're going to be covered for a cochlear implant. And we combine that with those outdated indications, and that means that the private insurers usually have strict indications. Again, we also have that some clinics are willing to seek pre-authorization outside those indications while others won't. They don't have the manpower to do it. It takes a lot of time, a lot of effort. Or they might not just know how to do that. They've done it sometimes and it hasn't worked, so they sort of give up. Where other clinics might be very good at it and be able to provide greater access just because they're better at communicating with the patient's insurance company. And again, there's the willingness or the ability of the family to request implantation. If they go to a clinic that's very strict and they say no, will that family know enough to perhaps seek treatment elsewhere if someone else is willing to provide an implant with a proven methodology and reason to do so. So one of the biggest issues is that hearing aid audiologists are very confused as to when it's appropriate to refer for a cochlear implant. Determining when to refer is really complex. And if we think about it, in the US, the standard of care for audiometric testing is thresholds, as well as unaided word recognition. So as an audiologist, if I do an audiogram, I get paid a little bit more if I use a code where I do the thresholds as well as the unaided word recognition. So most audiologists are really good at that. But if we look at CI candidacy, it's based on the audiogram and aided sentence recognition. But diagnostic audiologists rarely perform aided sentence recognition testing. Even audiologists fitting hearing aids rarely perform aided sentence recognition testing. So without doing those tests, how would they know when to refer for a cochlear implant, especially if all they've done is an audiogram? And we would go to our state or our local or our national meeting, and hearing aid audiologists would come up to us and would say, when should I refer? What's a good guideline for when I know to refer for a cochlear implant? And I would say, well, you could send me their audiogram. And then I'd think, well, that's not good. I can't look at every single person's audiogram. That's not a great answer. And I was kind of embarrassed because I really didn't have an answer to say to them. So what we did is we went back after attending a few of these meetings and said, we have to have a better answer for these people when they ask us when to refer. So we retrospectively looked at preoperative data for 529 patients that came in for a cochlear implant candidacy evaluation. And we looked at people that started coming in January 1st, 2016, because that's around the time frame of when we started administering AZ biosentences in a +10 signal to noise ratio. And that was sort of our cutoff. If someone obtained a score that met indications, when we presented it at +10, we considered them a candidate. So of those patients, 250 met traditional candidacy indications and 279 were non-candidates. So when I say traditional, we were really strict. They had to score less than 60% in that +10 signal to noise ratio on AZ biosentences, and they had to have a bilateral moderate to profound sensory neural hearing loss. And we really wanted to know if 2 routine audiometry measures could be used to differentiate candidates and non-candidates. And could it help us determine or give people recommendations about who should be referred for a cochlear implant evaluation? So we looked at the two primary components of the audiogram, the unaided thresholds for each ear, the pure tone average, and we looked at the unaided monosyllabic word scores. And we actually utilized the referrer audiograms because we felt like that represented clinical care. And so I put up here an example of an audiogram that a patient brought in with them for an evaluation. So we would look at those thresholds and we calculated their unaided pure tone average at 5.1 and 2000 hertz. And then we looked at their unaided word score. So in this example, the patient has a word score of 60% in the left ear and 20% in the right. But typical of the audiograms we received, we don't know if those words were administered recorded or live voice. And we also don't know what word list was used. Was it NU6? Was it CNC? Was it CIDW22? But we accepted all those comers because we really felt like that represented the clinical care that was being provided and that referrers were basing their decisions about referral upon. So when we looked at our traditional candidates, so we had 250 of them, we decided to break them down based on looking first at their unaided better ear pure tone average. We looked at the better ear because remember, we based it on that traditional definition of a cochlear implant candidate, which was really their best aided condition, which was impacted by their better ear. So if we look at the left side of this graph, we can see that the bars are broken down into ranges of pure tone averages. So 100% of our patients had a pure tone average that fell between 30 and 120. Then we narrowed it down to 40 to 120, 50 to 120, 60 to 120. So we could define where did about 90% of our patients fall. And what we found was that 95% of our patients had a better ear pure tone average that was between 60 and 120 decibels. So we said, okay, there's one of our landmark things, 60 dB. And a lot of talk was around 70 dB, but I felt like 60 dB probably captured that a little bit better. Then we moved on to look at unaided word recognition, again in that better ear, because that will contribute to that best aided condition. Now, we only had 196 data points because not everyone collected unaided word scores, but we broke them down similarly, but it goes in the opposite way. So here we've got 100% of our candidates scored between 0 and 90. Then we went to 0 to 80, 0 to 70, 0 to 60. We wanted again to see what fell closest to 90%. And there we came up with 60. So 92.3% of our patients had a better ear word recognition score that was less than 60%. So out of that came the 60-60. And what I want to show you, which is really interesting here about this word recognition score, is that when we look at the proportion of patients, so we're now going to the right-hand side of this slide, we see that 51% of the candidates demonstrated an unaided word score less than or equal to 20% in their better ear. So this means they're missing 80% of the word scores. And really what that told us was those patients were probably candidates 5 or 10 years ago and really should have been referred sooner than they were. So it's really important to sort of look at your data set and give you a feel for how bad off our patients are when they arrive at our clinics. So we wanted to look and say, would these 60-60 measure work? So we looked at the hit rate, and we had 415 patients that had both data points. And so when we looked at those patients, it was accurate for 340 out of those 415. So 82% of the patients, the 60-60 helped differentiate between a candidate and a non-candidate. But that also meant that we had a miss rate of 18%. And that 18% included 8 candidates who were missed. So 8 candidates, they met the traditional indication, but they didn't meet the 60-60. And then we had 67 non-candidates who did meet the 60-60, but were not traditional implant candidates. But we really felt that was okay because we would rather have non-candidates show up than have candidates not show up. And of those 67 candidates, many received a cochlear implant despite that they didn't meet the traditional indications, because we were able to go outside of their insurer's indications or outside the FDA indications once we received permission from their insurer to do that. Many returned the following year and eventually became candidates, and that enabled us to catch them early. I firmly believe if we catch more patients early, then those average scores that we see across the nation are going to go up because patients do better. Many non-candidates returned to their referring audiologist, and they were motivated to purchase new hearing aids. A lot of them come in and say, you know I need new hearing aids, but before I purchase hearing aids, I want to see if I'm a candidate. And when they weren't a candidate, they'd say, okay, I just needed to know that, and I'm going to go get my hearing aids now. So we really don't feel like that miss rate is a bad thing at all. When we sent it for publication, it came back with positive comments, but they really wanted us to do a little bit more analysis. So they wanted us to look at sensitivity and specificity. So for sensitivity, we're looking up and down here. How sensitive is it to correctly classify someone as a candidate? And because we really only missed 8 people, our sensitivity was fairly high at 96%. Our specificity, because it included all those 67 non-candidates, our specificity wasn't quite as good. It ended up being at 66%. But again, we were really okay with that. We'd rather err on that side. They also wanted us to look at positive and negative predictive values. So for these measures, we go across the top rather than up and down. And out of those, our PPV, again, was a little bit lower because it includes those 67 non-candidates. And if we look at the NPV, which is the probability that a patient will not meet traditional indications if they do not meet the 60/60, was fairly high at 94%, because we only had those 8 candidates that were missed by that. So after we demonstrated the value of that, otology and neurotology agreed to publish the 60/60. So really the 60/60 just states is to consider a cochlear implant evaluation. So one of the things we remind people is this is to just go be evaluated. It's not a recommendation of when to implant, it's when to refer. So patients who have a pure tone average greater than or equal to 60 dB in the better ear, or a unaided word score less than or equal to 60% in the better ear, should be referred for a CI eval. We also know that functional questions such as, do you struggle to hear on the phone? Do you have difficulty understanding others, as well as other questions, really can contribute to that decision of when to refer. So people, when we talk about the 60/60, I always recommend that they keep in mind that it's a tool to help clinicians determine when they're good for a referral, not for it doesn't determine candidacy. And it's really based on a very strict interpretation of traditional indications. So if you're referring to a clinic that's possibly using a +5 signal to noise ratio for AZ biosentences, well, then you're going to have a higher hit rate because you'll end up with more candidates. And patients with SSD, EAS, asymmetric hearing loss are also receiving cochlear implants, and they're doing well, but the 60/60 does not apply to those patients clearly. We also remind people that it's important to keep in mind that when we look at the 60/60 data, that patients often scored higher on their unaided scores than they did in their aided word scores. I think clinicians will see an unaided word score and assume that a patient's going to do better than that when they get put in the booth. But if we think about unaided testing, we're looking for PB max, we're presenting it at a very loud level. Oftentimes it's done live voice. So patients tend to do better than they do in the CI eval, where we're basing candidacy decisions on aided scores. So a little while after we published the 60/60, someone sent me a copy of this article by David Lee, and my heart skipped a beat because it was an external validation of cochlear implant screening tools, and they included the 60/60 along with 5 other candidacy evaluation referral screening tools. And we were very happy to see that Lee et al. Found that the 60/60 demonstrated the best overall performance on external validation. And they did not propose a new screening tool, but they did indicate support for use of the 60/60. And since then, Reddy et al. At MUSC looked at using clinical audiology measures to determine cochlear implant candidacy, and they did response operating curves. It was more detailed than the analysis we did on the 60/60. And what they found was if they used a +10 signal to noise ratio in a score for AZ Bio sentences, whoops, sorry about that. If they look at the response operating curves, a 1000 hertz pure tone threshold greater than 50 dBHL, or a pure tone average greater than 57 dB, so that's pretty close to 60, and a monosyllabic word recognition score less than 60% can each serve as individual indicators for referral for a cochlear implant evaluation. So clearly we're not the only ones that are landing on the number very close to 60. And I like to put this slide up because it's one of those text messages I received. My daughter was at AAO last year, and she said, she's an audiologist, and she said, "Hey, Mom, look, somebody's reporting on the 60/60." And I love that, excuse me, people are evaluating the 60/60, and this was Erica Woodson et al. And they feel as though the 60/60 is too stringent. So they recommend using the 60 or 60 for referral. And many clinics are using the 60/60 for referring an individual ear. So if one ear meets either a score less than 60% or a pure tone average greater than 60, they'll send them on to a clinic. So lots pointing to that 60 number. If we look at children, Lisa Park and colleagues recommend a 50/70 guideline for referral for pediatric CI candidacy assessment, which is a word score less than 50% correct, an unaided pure tone thresholds that exceed 70 dBHL. And they also recommend looking at if the child has poor functional performance, limited progress in language or auditory development, and poor quality of life as a result of their hearing loss. All right, so I thought it would be good just to look at a couple case examples of the 60/60. This is that case I put up early on. And what I like about this one is if we look at the pure tone averages, they meet the 60/60 as well as with that word score. But this patient brought this in and their audiologist wasn't really looking at them as a possible implant candidate. They were using the audio to update it for new hearing aids, but the patient came in despite that. There's those scores up in the top right, those unaided scores. And then here's our candidacy evaluation results. So their CNC scores were 8% and 24% for the right and left ear. And that's compared to 20 and 60%. So again, we see those live voice, well, if that was live voice, those unaided scores being higher than our aided scores. But if we look at those sentence scores, they clearly met indications. We didn't even have to administer noise because in quiet, their best aided sentence score was 28%. We provided this patient with a cochlear implant in their right ear, their poor ear, thinking that they'd probably continue to use that hearing aid in the left ear. That's exactly what happened. And look at these phenomenal outcomes. Their CNC score went up to 82. Their AZ Bio quiet is 98. And really what's most impressive is that bimodal score in the +10 signal to noise ratio of 79%. This person is back talking in a restaurant, can really tolerate sort of typical levels of background noise. We've got another patient here, maybe, maybe not. This might be borderline because we've got pure tone average of 65 and 60. Their word recognition scores are 48% in each ear, but this was an internal referral at the University of Michigan. Actually, then we looked at their, when we do evals, we always verify the hearing aid fitting. And when I talk to referral sources, I let them know that the purpose of verifying is not to check their work, because when you're verifying a hearing aid and you're fitting it, you're definitely going to adjust it up or down based on patient feedback because you want them to wear it and you want them to utilize the hearing aid. And if they don't like the targets and they don't like the way it sounds, they're not going to wear it. So a lot of the times they're not meeting targets when they come in, but if we're basing candidacy decisions for a surgical procedure, we really need to ensure that we're using best practices and we're meeting targets. So in this case, we programmed clinic loaners and we reassessed them. Patient said, I think I hear better with my own hearing aids. So we did a little bit of testing with both, with our aids, with their hearing aids. And what you see down there on the bottom When we used the personal aids of this patient, they met indications. They scored 48% on sentences at +10. But when we used hearing aids that were verified and met targets better, their score exceeded 60%, and they were not a candidate. They scored 73%. So in this patient, they were referred back to their dispensing audiologist with a recommendation to consider reprogramming or replacement of the current hearing aids that they were utilizing. All right. So with outcomes like these, like, why aren't more patients being referred for cochlear implants? I'm sure you see them in your clinic. Our patients are really receiving phenomenal outcomes. Well, there are some possible clinician factors. Maybe there's some clinicians who don't believe that implants work. Maybe there's lack of simple information regarding when to refer. We see that there is now simple information, but maybe we haven't educated our colleagues about those simple numbers. I do believe that when we say these numbers, it's funny because at AEO, someone put up that it's too strict. If you talk to a lot of hearing aid audiologists, they'll say that it's way too lenient, that people that have a pure tone average of 60 dB are doing way better with hearing aids and they're not considered an implant candidate. So I do believe that there's a disconnect between what hearing aid audiologists think patients are doing compared to what a CI audiologist would believe when they look at that audiogram and look at their test results. And then there's some people that feel clinicians want to keep them in hearing aids so that they can, profit from the hearing aid sale. There might be a few clinicians out there like that. I don't think there's many, but I think if there are a few, they're giving all of us a bad name. So I'm hopeful that even those clinicians would see the light and see that those patients are much better off with a cochlear implant. And then we have patient factors that are keeping some of our patients away. They're afraid of losing their hearing, and they're worried about the cost, and they're still fearful of surgery. And really, when this comes up, I always say to the referral sources, the best way for a patient to learn about surgery is to talk to a surgeon. I don't think I should talk to them about it. I don't think that a hearing aid audiologist should feel like they need to be responsible for addressing the issues related to surgery. They should really refer them on for a cochlear implant evaluation, give that patient the ability to talk to an audiologist who works with implants and a surgeon who does cochlear implants so that they can really have educated information about the surgical aspects of cochlear implants. So I think another area we need to look at is, our clinicians following best practices? So best practices are the working standards or ethical guidelines that provide the best course of action in a given situation. So in medicine, we're typically basing this on evidence. And as hearing care professionals, I think we're ethically obligated to provide patients with the best possible treatment, which means referring them on to a different treatment if that really will lead to the best possible outcome. And if this is true, I still am amazed that we're missing so many of the candidates, and there are things that we can all do that we can all do better to improve care. So what are some of those things? Well, the patient journey shouldn't be so siloed. It shouldn't be, and now we've introduced OTCs, right? So we've got over-the-counter hearing aids. So we have a new silo. We've got OTCs, hearing aids, assisted devices is in there with overlay between all of them. And then we've got cochlear implants. So we've got these three silos. And rather than being siloed, we really should think about it as a continuum of care. And maybe when patients are first fit with hearing aids, we should talk about that continuum and let them know, if their hearing progresses, that there is something, down the road for them that, might be a surgical treatment such as a cochlear implant. And I really feel that patients need assistance along this journey so that they know when the time is right to transform to the next step, and that clinicians, all of us, are so vital in that process. I think one thing we need to do better is we need to communicate better with our referral sources. It's really hard for patients to transition from one stage to the next. And hearing aid audiologists and otolaryngologists are really vital in talking to patients in the best possible way to educate them so that they're willing to consider to go for a cochlear implant evaluation, so that they don't shut it down right away. And I find in a lot of my work that our referral sources are intimidated about that conversation when patients bring it up and they're not sure of what to say. So a lot of it is just talking to them and coaching them through the best way to communicate with patients when they want to refer them for a cochlear implant. We know that most of our patients receiving cochlear implants continue to use a hearing aid in their opposite ear, and this is a great opportunity for us to be partnering with the hearing aid audiologists, with the practices that dispense hearing aids. And if we can partner with them and have them not be fearful about losing a patient, that instead they might be gaining patients. We get a lot of patients that come in that haven't purchased hearing aids for a long time and want a recommendation of where to go. And if someone's referring implants to us, we're more likely to refer hearing aids back to them. I believe that implant audiologists can do a better job of communicating. When I used to present to the Institute for Cochlear Implant Training, and we talked a lot about communication with our referral sources. And I'm almost embarrassed to say that out of 50 audiologists, probably only 2 or 3 routinely send letters back to the referral source to let them know that they're a candidate and then to communicate them about the outcomes. And so implant audiologists, we're not as good as physicians. Physicians do a great job of communicating with their colleagues, but audiologists need to be better at communicating with their referral sources. We forget that our referral sources care about these patients just as much as we do. And so sometimes when I talk about it, I say we need to share the love. We're getting all the excitement from the patients, and we're not even letting the people that have held their hand for years ahead of their journey to us, let them know how they're doing. And there's this publication by Valerie Louis, who looked at referral rates for adults and really concluded that there needs to be enhanced communication between hearing aid and CI clinics. And again, we need to counsel better. Patients look to audiologists, otolaryngologists for recommendations, and we need to be confident when we recommend technology. We also need to look outside of our geographic location. This publication by Ashley Nassiri really showed that while large implant centers serve geographically dispersed populations, the vast majority of patients reside within a 200-mile radius. So we need to look outside of our standard care and really bring other technology into our standard of care, such as remote programming, telemedicine, strategic placement of new centers and satellite clinics to really try to have that access be there for those patients. And there have been a lot of recent publications looking at additional barriers to cochlear implant care, such as socioeconomic characteristics and racial and insurance inequalities. So we need to continue to evaluate what those barriers are. And then we need to do something about them rather than just, say that we know that they're there. There are a few national efforts underway to improve access to cochlear implants that I want to tell you a little bit about. The first one, I'm personally super excited about this. There's a group of professionals, Camille Dunn and I sort of led this initiative through the Institute for Cochlear Implant Training. Tom Balcony served as our methodologist, and we had a group of 12 content experts from experts in the field of cochlear implants and hearing aids. And so we decided it was time to revise the MSTB because the last version was updated about 12 years ago in 2011. So what we did is we broke them into groups, and they did literature reviews, and we held a modified Delphi process to derive clinical consensus statements regarding clinical care. So we incorporated current best practice metrics. We excluded unnecessary or outdated test instruments. When I describe it, I like to say that the previous MSTB started kind of big. It had a lot of measures, and in it, it said, if you have time constraints, narrow down your battery. Well, we wanted to do the opposite. We wanted to start with a narrowed down battery that will suit most candidates. And then we expanded out if you need it to obtain additional information that will help you derive information about candidacy for a cochlear implant. It really standardizes the minimum battery of tests used for cochlear implant candidacy and follow-up. And again, we developed it using a consensus process. So some highlights about the MSTB3. The test materials are going to be available in an easy to download format electronically on the ICIT website. There's going to be recommended test batteries for traditional candidates as well as SSD and asymmetrical and bimodal EAS. Because candidacy today is so much more than audiometric results, there's going to be recommendations for functional test measures and questionnaires, and even some recommendations of when to consider referring on for cognitive testing or to do cognitive screening. Although we did not come to consensus, the group did not feel that the field was ready yet for cognitive screening to be part of every adult test battery at this time, but there's comments made in the MSTB. So importantly, there'll be post-op protocols for access to consistent real-world data. So as we saw in those early slides, SSD, AHL were based on real-world data. So we know that that real-world data is important. And I think if you ask someone to go get real-world data, it's all over the place. But if we have clinicians administering similar batteries, then we'll have better real-world data so that those indications can be updated and improved. It includes report templates to help streamline reporting so that we're all sort of reporting in the same fashion, which again will help with that real-world data. And one thing is, it's very different. It's not a research protocol. We got a lot of great research out there, and those researchers have their clearly defined test batteries. It is a clinical protocol focused on defining cochlear implant candidacy and evaluating outcomes. So this is part of the MSTB. We have this lovely decision tree, which really will help clinicians. And I think in a nutshell, these squares really highlight the big differences with the new MSTB. We recommend that clinicians start with CNCs. If you think about it, if you might have some clinicians that get a patient, they put them in a sound booth, they do AZ bios at +5 with both ears aided, and if they score less than 60, they say, okay, you're a candidate, and that might be it. We know that could be problematic, especially with Medicare's recent expansion. We might have someone that scores 55% on AZ bio sentences at +5, but if we test their individual ear CNCs, we might find that they're at 80% in each ear. And to me, that would be a big disconnect. Why are they doing so well with CNCs, and why are they falling apart in difficult noise? And maybe the CNCs are more peripheral, and maybe those +5 signal to noise ratio sentences are more central. And maybe that person really wouldn't do well with an implant because the implant's gonna treat sort of the peripheral process, and they might have even worse scores in noise with an implant. So this really tries to take back the clinical recommendation and gives people, it does not give a recommendation of what scores lead to candidacy. It just gives recommendations about the tests that can be used to determine that. So we recommend that clinicians start with CNCs to base candidacy decisions on clinical recommendation. And this is sort of taking control over the candidacy determination. The group felt as though insurance companies were really driving who received cochlear implants rather than otolaryngologists and audiologists working together to decide who could benefit from one. So really the focus of this is to determine if you think someone's going to do better with an implant, and then you go see if they qualify based on their insurance recommendations. So you start with CNCs, you do best aided in the right ear by itself, the left ear by itself. We do recommend verification. And the second big thing that this does, which is that box in the bottom left, is it redefines best aided. If we think about best aided, it's never really been clearly defined. It's always been assumed that it means both ears aided, or the best of the right ear, left ear, and binaural aided. In this instance, the MSTB is redefining best aided as focusing on the ear to be implanted once it's been verified. So it's the best possible aided condition of the ear we're going to recommend for a cochlear implant. And we feel the time is right to do this, to consider the ear to implant based on the recent approval of SSD and AHL. So those are just some highlights of the MSTB. I hope people are interested in learning about it more. We're really hopeful that clinics follow it because we think it could bring about greater consistency, less confusion, and really improve access. There are some additional efforts that I'll briefly mention before we close. The American Cochlear Implant Alliance Task Force has several task forces who have developed guidelines related to determining CI candidacy. So they have separate guidelines for children and adults, and for SSD for children and adults. So if you're not familiar with those, I think it's helpful to read those. I know that there's one coming out from ACIA, and they will have a recommendation regarding what CNC score to utilize as a guide for determining candidacy. But again, that was not the purpose of the MSTB. So I finished a few minutes early, which I think everybody's happy with. We'll get you back to work sooner. So in summary, the benefits of cochlear implant are so clear. We've been in this for 40 years now, and they're safe, they're effective, yet many children and adults who are candidates still are not receiving them. And there are many efforts underway to improve access, including development of these simple referral guidelines, of management guidelines, these streamlined test batteries, and incorporation of additional professionals in cochlear implant care, such as networks where cochlear implant centers that have long waiting lists are now partnering with hearing aid audiologists to do the eval and sometimes to do some of the aftercare. And I think there's a lot of promise in that, because as patients wait longer and longer, we're going to have a backlog. And if that number is accurate of 10%, even if it's 20%, if we double that in the next couple of years, I'm not sure all the clinics can manage doubling the number of patients that they have when we think about the established base that many clinics are dealing with. So we really have to look at creative ways to improve access to care. And one of those ways might also be telehealth, so that we can make it convenient for patients so they don't have to travel in. People in remote areas or who can't afford to travel might still have better access to cochlear implants. So we've been doing these for a while. They're really good, but we still have a lot of work left to do. So thank you for your attention, and I'm happy to take any questions if you have any.